Good afternoon, everyone. Thank you for joining us today. I wanted to give you an update on our current trends. Today, we're reporting 894 new cases in the state of Oklahoma. As you're aware, we have technology challenges over the past few days, and we've been trying to navigate this pandemic with an antiquated system. The good news is we've worked through these challenges and we'll have full resolution on our dashboard in the coming days. As a result of the recent challenges, we've also uncovered a backlog of 820 positive cases not yet reported publicly. This brings the Oklahoma total cumulative cases to 27,147 as of today. Let me be clear, if a positive test was processed at a state lab, we are communicating to the person as quickly as possible. The backlog reported today is not indicative of our efforts to communicate directly to confirmed cases. Oklahoma's hospital infrastructure remains in a strong position for treating the current rate of COVID-19 cases. The percentage of active cases hospitalized remains less than 10%. The median length for hospital stay for COVID-19 in the United States is 10 to 13 days. In Oklahoma, this is 5 to 8 days. The risk of being hospitalized was 6 times higher for patients with underlying health conditions than for patients without them. This goes from 45.4% to 7.6%. These underlying health conditions are conditions such as heart disease, diabetes, and lung problems. The governor is going to be with us here to give us an update on how he's feeling, and I'm going to turn it over to the governor.
Okay, can you hear me okay, Colonel?
Yes, sir.
All right, thanks so much for the update. Well, I'm first just start out, I'm feeling 100%, feeling really good, like a lot of Oklahomans, would never obviously miss work during this. I feel 100%, just a little bit of a couple days ago, just a little bit of a maybe stuffiness in my head, but really feeling great. Just missing my wife and kids, and being quarantined is not very fun. So, but also great success story. No one that I came into direct contact with since last Saturday has tested positive. So we're not out of the woods yet, but it underscores the opportunity for Oklahoma to tackle COVID-19 when we take personal action and listen to the guidance from our public health officials. I didn't have the traditional symptoms of COVID-19, no fever, no cough, no shortness of breath. But instead, the moment I felt just a slight hesitation that something was off, I took action, wore a mask into the office that day. When I was speaking to others, I was very conscientious of staying 6 feet away. I immediately sought out a test, and then when Dr. Frye advised it, I quarantined. I've stayed isolated ever since, working from Zoom, and I'll continue to do so this week. So it just shows you we can minimize the spread of COVID-19 when we work together and when we realize our personal actions impact our neighbors. So we're in a new normal. I talk about that a lot. That new normal means we have to be more aware of our surroundings and be more conscious of washing our hands, wearing a mask when it's difficult to social distance. I have family members that would really be in considered a high risk category, and we continue to do our best to help them minimize their exposure. We visit them when we can outdoors together, help do their grocery shopping. We encourage them to get tested. My dad, for example, called 211 the other day to get scheduled a test when he was in Tulsa. I want to also take a brief moment just to thank all of our Oklahoma's nurses, doctors. These folks are really on the front lines doing a tremendous job of helping Oklahomans. They're in our hospitals treating all the patients for COVID-19. So I want to give them a shout out. They're doing a fantastic job. Commissioner Frye has been working closely with several of our hospital CEOs across Oklahoma to help modify our hospital surge plan. And today's modification will expand our COVID-19 flex centers from 2 to 7. This adjustment increases our COVID-19 flex beds in the Oklahoma City metro area by 125% and gives us the ability to treat more patients. But in the event of a surge, while keeping Oklahomans in their communities, it's really going to help. By adding more COVID-19 flex beds, the state is partnering with the medical community to deliver the highest level of care in hospital settings, instead of turning to temporary field hospitals, as we've seen common in certain other states. These flex beds will also allow hospitals to continue to offer services as usual, such as elective, non-emergency surgeries. But just wanted to remind Oklahomans, should Oklahoma experience a worst case scenario, we always have the levers to pull to limit non-emergency surgeries across different regions of our state to make more beds and staffing available for COVID. But we do not want to get to this point. That's why we need Oklahomans to practice public health measures so that we never have to flip these switches. And again, I think Oklahomans have done a really good job, better than any other state. We've got one of the lowest, we're in the bottom 10% of number of cases per 100,000 population. So really excited about that. And we've been fully reopened now since June 1st, and we started our reopening plan on April 24th. And we've seen kind of the positives start to plateau. And so really proud of Oklahomans. They're really doing a great job. Also, thanks to our early efforts, our state emergency stockpile of PPE remains strong. We've got over 2.5 million N95 masks on hand. So really feel like we're in a great position on the PPE side. We continue to monitor that daily, get reports from all of our hospitals, our first responders across the state. So thanks, Oklahoma. I'm doing well. Thank you so much for all the prayers, the texts, the home remedies, taking a lot of vitamin C, vitamin D, zinc, getting all kinds of recommendations of immune boosters. So thanks for all that, and doing well. But I'll turn it back over to the commissioner now and the hospitals to walk through their details of these modifications. Back to you, Commissioner.
Thank you, Governor. The core aspect of our original hospital surge plan remains in place. I want everyone to know that we've deployed 25 of the 53 telehealth units statewide. We've continued to work closely with our state hospital partners and the Oklahoma Hospital Association as they manage their capacity, recently updating our plan and adding 340 additional beds, that are available in addition to the hospital's normal capacity. We still have available through the Army Corps of Engineers the ability to add 125 beds in Tulsa and 95 in Oklahoma City if needed. And as the governor said, the Department of Health's warehouse is full, literally, of PPE. We have enough to sustain us through many months of heavy usage if necessary. In addition to the N95 masks that the governor spoke of, we have 28 million gloves. We have 1.5 million KN95 respirator masks, 4 million isolation gowns and protective coveralls, and 3 million face shields. We've been working hard with our hospital partners to increase capacity, and we're sitting here today wearing masks because we are in a room that we can't social distance in, so we're taking the necessary precautions. I want to thank them for being here and for their hard work, and I'd like to turn it over to them for some comments. First, it's going to be Chuck Spicer, President and CEO of OU Medicine.
Thank you, Commissioner. We are happy to be here in a collaborative effort to spend a couple of weeks that we engage as an industry to come together to provide additional capacity, knowing that we want to manage COVID and non-COVID patients and people that are sick get the care they need. In addition to Richie and Jim that are here, I want to thank Clay Franklin from Midwest City and Community Health, Joe Hodges from SSM, and Tim Pearson from Integris. As OKC Metro CEO collaborators, they and their teams have been instrumental in us getting this plan together as well, and we thank them. The capacity is more than just physical bed capacity. It's a commitment of physicians, nurses, and staff doing everything they can to take care of the people that need care. Again, the vast majority of these people are non-COVID patients in our hospitals, and we're committed to staying open for those patients as we still deal with the pandemic. But it's, again, a collaborative approach, one that I'm really proud to be a part of, and one that I think we'll look back at bringing our community closer together and stronger as a medical community. Wear a mask, because you don't know if the nurses that might be taking care of you, you can prevent it from contaminating them and infecting them. When you're in the community, it's important to remember everybody that you're encountering, maybe encountering a healthcare worker. So keep that in mind, and thank you for your time, Commissioner. And Jim, I'll let you make some additional comments.
So thanks, Chuck. I would say, first of all, that we're very pleased to be here today and to collaborate with the state officials. I assure you that our objectives and our motives are absolutely aligned in making sure that we have the capacity to take care of all Oklahomans, and especially those who reside in the Oklahoma City metro area. You know, managing capacity is a daily, if not hourly, job that we all have in the health systems. And so we have tools at our disposal where we literally monitor things, not by the bed, but by the minute throughout the day. And so our teams are looking at moving patients through appropriately the different care locations across the metro area. In doing so, we think that we're providing the highest level care anywhere in the country, and appreciate my colleagues in doing that. We also manage a lot of human resources, and been a lot of questions about that. And to Chuck Spicer's comment about the nurses and doctors, we do want to say thank you to all of the frontline caregivers for all the things that they do, but also to the folks who work in food services and in environmental services and all the other services that make these things happen. They're working really hard. So the governor and his team, I can't imagine them doing any more to provide additional capacity for the residents of our state. They've literally helped us with physician staffing, with nurse staffing, and the governor talked about and the commissioner talked about PPE availability. I can tell you that at Mercy, we tapped into that early on, and we got some of that PPE for our staff to use when it wasn't as plentiful as it is today. I can tell you that this surge is real. On July 2nd, Mercy had 16 patients. Yesterday, we had 39. So I don't want anyone to think that there aren't a lot of people being hospitalized around the state of Oklahoma. So this is an effort to provide additional capacity, and we believe that we can do that. I want you to know that all the health systems across the metro area, we're committed to provide this capacity, and we're committed to providing the highest level care anywhere in America. I'd like to introduce now Richie Splitt, who's the CEO and president for the Norman Regional Health System.
Thank you, Jim. I too would like to thank Commissioner Frye and the governor and his team for this opportunity. I believe you've heard already, the word is collaborative. This has truly been a collaborative effort between all parties involved. We have a very good plan in place, and of course, we hope to never have to activate that plan, but should we have to activate it, it's a very good plan. We have current capacity to meet our current medical and surgical needs, as well as those COVID needs. This model is distributed around the metropolitan area of Oklahoma City. It maintains our current referral patterns. It keeps patients closer to home in their communities should they need that level of care. And again, very collaborative approach. We're grateful to be a part of that. And we know that this plan will work if needed. The best thing we can do to prevent the plan from being activated is to wash our hands, socially distance, wear your mask as appropriate. And again, it's an honor for us to be a part of this plan and to serve the Oklahomans all across our state and be prepared for whatever comes our way. At this time, I'd like to introduce Eric Pollock. He is the CEO of OSU Medical Authority and Trust. He's joining us by Zoom.
Thank you very much. I appreciate the opportunity to be here today from Tulsa, just up the turnpike, and I'd like to echo largely what others have said here today. OSU Medicine and the OSU Medical Center, we view our role as a state resource, and we're happy to work in collaboration with our management partner, St. Francis Health System here in Tulsa, to continue to stand up resources that are necessary and needed to care for the hospitalized patients that continue to enter into our facility. Like others have said, the surge is real. It's happening. We are seeing an increase in patients. OSU Medical Center is up to 21 patients as of this morning that are COVID positive or under investigation in that. But we continue to bring on resources as they're needed to activate more and more beds as the patient demand requires. So we're happy to be a part of this. We appreciate the partnership with the Department of Health, much like everybody else has said, and I would be happy to turn it back over to Colonel Frye at this time.
Okay, thank you, Eric. We're going to open it up for questions at this time. Our staff here will be managing the questions, so we'll be calling you out by name, and then asking you to ask your questions.
First, we have Cassie from the Frontier.
Yes, thank you. Colonel Frye, you mentioned the backlog of test results that was discovered recently. Can you tell us a little bit more about that? When was it found? How was it discovered? And when were these cases from?
Yeah, I'll happy to talk about that a little bit. So the system we use is called the FIDO system, and it really was never built to take on a pandemic. And so we are working with a company to basically do a kind of a patch it until we can get a new system. And so as they're working on that back end of it, it crashed several times over the past week. And so we ran a sweep through there basically to look to make sure if there were any cases that were sitting there that we needed to make sure we process through. And there were those 800 and some odd cases. Now, I don't know when those cases, when they were run, and that's not that those people haven't been notified of the positive cases. They just haven't been reported out yet in the system. And so I don't know the exact dates on them, but we're going to be putting those into the system tomorrow.
Okay, we have Dylan of KOCO.
Hey, Commissioner, I have a follow-up from Cassie's question and then one other, if that's okay. The follow-up is, those 800 cases, are those the basically the underreporting from the past 2 days, or are those a separate backlog that you've now identified? Basically, are we up to all the cases that have been reported now? And then 2, on the hospital capacity, are you guys factoring in any concerns about staffing? We've heard a lot of concerns about actually staffing all of these extra beds that may be needed. Thank you.
Yes, so it is part of the backlog from the underreporting from the last few days, but so that's a part of it. I mean, there are some that were that may have been from longer than that. The thing about our system is sometimes the tests may have been run, depending on what lab they're run through, prior to the day before. So some of these are send out labs or whatever that they report into us. They send those results back. And so I'm not sure the exact day that those tests were actually run on, but that is a backlog from the underreporting for the last few days. And actually, I'm going to turn over the staffing. Chuck, do you want to answer about the staffing?
I think that's actually a great question, and the value of the distributed model. It would be hard, if not impossible, for any one hospital to staff up 100+ beds on their own. But by distributing across six systems, it gives us a whole lot of better ability to do that. But again, we want to make sure our staff stays safe. And we've been very safe inside hospitals across the metro. But I think we all feel confident in our ability to manage our staffing. And we've done it before in tight times in the winter and other times. But again, that's the value of the distributed model.
Right, next we have Rebecca with Fox 25.
You mentioned that the system has crashed several times over the past week. Does that mean there's any question about the accuracy of these numbers today, and are you all caught up?
Well, we will be all caught up once we put these in. There's no question about the accuracy, because anytime that's done, for instance, it went down early this morning. It took us till just maybe an hour ago to get the system back up. And the reason it takes so long is because we go in and we re-verify every one of those cases to make sure they're not duplicated. So it's accurate, but it's just an older system that luckily we've been we've been granted some money through the CARES Act to replace it. And so we're working through that process now.
We've got Derry from News 9.
Hi, thank you. Just to kind of reiterate on to kind of add on to Dylan's question about staffing, I know that Integris Health specifically has been contracted out for additional staffing to open up their Portland Avenue campus. Is the State Department of Health or are any hospitals here exploring ideas of contracting out or bringing in outside help should that be necessary to staff hospitals?
I'll let the experts here talk about that.
Go ahead, Richard.
Staffing is a routine, ongoing issue for all hospitals and health systems. It's something that we deal with day in and day out. And in terms of a specific response to this question, yes, we are. I'll speak for my own health system. That is something that we are looking at. It's not a typical tool that we use. We're very fortunate that we can attract and retain staff to care for our patients within our system. But in these circumstances, we are looking at that possibility that we would look at some contracted labor that would help us to care for these additional beds if needed.
Yeah, again, I think 20 incremental beds is much easier to staff. So we have a great group of nurses at OU Medicine that can flex up and down as staffing is needed and have an internal pool of resources we can allocate for premium labor. But we would certainly look at contract labor if necessary, but we've got a strong team we can count on.
So for Mercy, we have 13 hospitals around the state. We're actually looking at, can we deploy some of those nurses from other hospitals around the state where they're most needed? Can we admit patients to a hospital that makes most sense for that patient's condition? All of those things play into the staffing question.
We've got Trace from Mondoc.
Yes, Commissioner, thank you very much for your time today. The city of Altus in southwest Oklahoma is seeing a high number of COVID-19 cases, including a confirmed outbreak at the hot dog factory there. Can you give us an update on how things are going in Altus? And when you're talking about hospital surge capacity, do folks go to Lawton there? Are there folks coming from rural southwest Oklahoma who end up in Oklahoma City? What's the process for when you have an outbreak like that and a bunch of people who may need to be hospitalized?
Yeah, we're certainly monitoring and working with them on that outbreak and trying to provide them with anything that they need to move through that. Luckily, I wish we didn't have any outbreaks, but we've successfully worked through several in the state already. So I'm sure we'll be successful with this one as well. But we have a regional plan in the state of Oklahoma for our emergency preparedness people, and we have there are regional medical centers, and they all have their own referral patterns. And so we encourage them to use those, but we do have a system in place with our surge plan to help them through that process if that is difficult to navigate. So, but some of those patients may end up at their regional medical center, and if they need to, they would then transfer into the metro areas. I'm not aware of them transferring them in at this time, but that's not to say that they haven't transferred any. I'm just not aware of any of those cases.
We have Russell of KRNG.
Are you able to hear me?
Yeah, I can hear you now.
Okay, good. So my question concerns ICU bed capacity. I know that we have, maybe several thousand beds, but I understand that our capacity for ICU beds is running around, I don't know, between 15 and 20%, most of the numbers that I've seen. And a quick follow-up on contract labor, one would imagine that there's quite a bit of competition around the country. So if you're trying to contract people from outside the state, I'm curious if there's actually a pool of people available.
So on the ICU question, if you would have asked us, 6 months ago about ICU capacity, the answer is probably the same as it is today, that we manage ICU capacity pretty efficiently. And so at Mercy, we have 36 dedicated ICU beds. but we have a plan to be able to expand that to 56 beds and then even further. And so the issue for us is really making sure the patient's in the right level of care, the physicians then transitioning them to the next appropriate level of care as you know, we work to overcome this virus. For all hospitals across America, we manage ICU capacity very tightly. And so we don't have a lot of extra resources on hand, but we haven't had a situation at Mercy where we've ran out of capacity in the ICU.
And I think back to the staffing, I think all of us are looking at other options before out of state is access to the labor pool. And I think we all feel like we can be successful. Again, talking about an incremental surge of 20 beds per health system. And as a percentage of our total beds, that's very manageable.
Okay, we're gonna take 3 questions. It's gonna be Paul, Carmen, and Janelle, and then we'll have to close it down. So I'm unmuting Paul Monies of Oklahoma Watch.
Hi, can you hear me?
Yes.
Hi, Commissioner Frye. Just wanted to check on some hospitalization details that you might have internally. Is there any way we can get, you know, hospitalization by county or area or region? And then also, are you seeing a different mix of patients in hospitals now versus, you know, the last surge at the end of March?
Paul, I don't have those numbers with me, but we're happy to get those to you. And there is a difference because we had when we were shut down with our economy, then we had certainly a different mix of people in the hospitals than we do now. We didn't have the trauma mix there that we're having. I have these experts here with me to help answer those questions, so I'm happy if they want to chime in on it. But
you know, I think the mix is variable across the hospitals in terms of the COVID patients we're seeing. I think it's not the acuity we saw probably at the early part of the pandemic. They appear to be more manageable, but that's different by facility. And our non-COVID business resembles what it did before we did the shutdown, and I think that's good for people that need care.
So the length of stay for the COVID patients has declined. Was mentioned earlier that the average is 6 to 8 or 6 to 9. At Mercy, that's about 7 days now. Early on, it was about 14 days average length of stay for a patient. The average age was in the 70s, and now it's in the low 60s. So we know that we're seeing younger patients as well.
I think I would simply add that speaking to the nature of those COVID patients, roughly on average, 25% of our in-house COVID patients would be a higher level of acuity, a more severe illness, maybe on a ventilator. So what we're seeing is a lower acuity, lower illness, if you will, lower severity of illness with a little bit longer length of stay. Again, similar to Jim, as he's described, 6, 7 days. And we're managing those patients very effectively, much more efficiently than we have in the past.
Okay, we've got Carmen with the Oklahoman.
Hi, thank you so much for your time. I just have a quick clarification question. So the surge plan adds 340 beds across 6 hospital systems. And I'm curious, is that OKC and Tulsa? And then I would be curious to know how many hospitals among those hospital systems would receive additional beds under the surge plan? So
that does include Tulsa. And that also includes the 95 beds that we still have on hold under contract that we can execute through Integris at any time that we'd like to. And then there are a total of 7 hospitals in the Oklahoma metro area and the one in Tulsa.
And then we're gonna get Janelle. Okay, Janelle, there we go, Janelle.
Hi, I had 2 quick questions. There have now been 3 straight days of COVID-19 case reporting technical difficulties. Is this going to be an ongoing problem, or has it been resolved going forward? And when do you guys hope to finish modernizing your system using your CARES Act funds?
Yesterday would be my choice, but you know, it's hard to predict whether it's going to be ongoing. We hope that the updates that we've been making will help the system. We knew that we were basically patching it for now until we could get a new system in. We just didn't know that while we were doing this, we'd have these additional problems. They do have it back up and running today, and hopefully it'll stay that way. Okay, thank you all for coming, and we're going to stop the press conference at this time. But